so far, we have seen some of the basic components of the claims process flow, the adjudication process, and also we have covered the insurance plans and the different products on the day 1 and day 2. So today we will be talking about EDI claims. So because any organization that you take, whether it is a payer organization or a provider, EDI is a basic component. Without an EDI, there would not be any electronic transactions existing it. So it is important that we all have a good understanding of this EDI. The infrastructure, the system, the applications, which generate the electronic transactions. So that's the reason we want to dedicate one good session for EDI. And then pick up one particular transaction, say for example A37, and go see thoroughly from end to end, what it comprises of. So that's the reason today we want to fully talk about A37 transactions with EDI in focus. Because if you take even clearing houses, they should have an EDI infrastructure in order to exchange the health information. So it's so important. And since our focus is for the BA to give them domain knowledge, and it's more likely that any one of the new BA resources would be ending up in an EDI environment. So we need to understand, how these transactions they get, communicated between the two different systems. So, and then we'll also look into the edits and validations that happen. We'll be looking into some acknowledgement reports. And even though I have listed A35 in today's session, what I've seen is, A37 itself would take quite a good amount of 2 hours, and that's the reason I have moved A35 onto a different day. So we'll talk about A37, edits, validations, reports, and acknowledgements that we get back, when we send the transactions. Okay, so before we start, any questions that you would like to add? Anyone? All right. Okay. Hello, Kanal. How are you doing?
Hi, Raghu.
Hi. All right. So I think that's good. So we got all the team members on the call. So let's start. Hope you are able to have this audio video without any issues, right? You're able to see and you're able to hear. Okay, so I close this participant window so you could see the full view of this PowerPoint. Okay, so let's talk about this EDI. Now, EDI is basically an infrastructure in every organization should have it, right? So it basically enables electronic transmission of healthcare information. I mean, here in this case, we are talking about the healthcare information. So all the healthcare standard HIPAA transactions are sent through an EDI. So from where does it send? It's basically a communication between a computer to computer, from a provider to a payer, and a payer to a clearinghouse, or from a clearinghouse to the provider. So whoever it is in within the network of computers, whoever has this similar setup of an EDI, they only would be able to send and receive the transactions. Plus, they would be able to provide a handshake of these transactions. That means they will acknowledge the receipt of the transactions from one computer system to the another computer system. So that's how basically an EDI will operate, right? So without any human intervention or reaching any other information, without any manual tracking, these transactions, sending and receiving would happen automatically. So that's what is a basic advantage of having an EDI environment. So it's basically your computer hardware, with some servers on it and a data warehouse capability, and plus having an EDI software on it. So there are several software companies that provide this EDI exchange. Some of the companies that would do is ASC. Then there's an HP also that provides EDI software. Then there's another company called Ingenix. So there are different companies that provide these capabilities. So that means Edinet is also another software company that provides the exchange of EDI, transmission of EDI transactions. So there are n number of software companies out there in the market, and any EDA software that runs on our computer system, and basically that has to be in compliance with HIPAA transactions, right? And also any provider and a payer who is communicating these electronic transactions, they have to follow these standards. That's number one. And number two, the versions of the transactions have to be same. For example, currently we are using 4010 transactions, so that's a version number. And even the receiving organization should use the same version number. If you are moving on to the next version, for example, 5010, then at the same time, both organizations have to be moved to the new version. So it's okay to run in parallel both the versions, but if you have to exchange in a different version, then both the systems have to be on par with the same version. So that's how it operates. What I'm listing here is some of the benefits of the EDA environment, so that you would really appreciate, the availability of the EDI system. Number one is your review cycle time. Since it's all automatic, like a push of a button, you run your transactions and send it out, boom, it's out there in the receiving organization. So in that way, by the time you send the transactions and the claims are adjudicated and then the remittances are coming back, it's all automatic, so there's no manual intervention. And in that way, your cycle time for revenue cycle time is much more less than you would have done manually. Better inventory management. So you don't have to manage a huge number of data storage for storing the transaction. Since this clearing house is clean, so some of the infrastructure can be moved over there. And since everything is in a kind of electronic media, you can avoid of the manual heaps of paper documents, to keep in case you need to verify at a later stage, even for it's for internal purpose or it's for any legal purposes. So you can always retrieve those transactions, take a print, and then send it for your internal reviews for any other purpose. So in that way, you can save a lot of inventory management. Increased productivity. Since we are talking about EDI systems, it's all kind of automatic, and we can really reduce the number of headcounts or manual manpower that are engaged in EDI activity. So that really directly increases your productivity. Reduces the cost, since we are employing a less number of manpower to manage the EDA software, so automatically it reduces the number one, it is the infrastructure cost, and number two is the cost of transmitting the transactions. So that's the advantage of EDA transactions. And since we are using the EDA transactions, that enables us to be consistent, across all the organizations within the country. That's another bigger advantage we have by utilizing the EDI concept. It improves accuracy. It's all electronic, so it's, wherever there is a less involvement of a human, there is always there are chances of data to be accuracy, right? So you can improve the accuracy of the transactions. Improve business relationships. The reason we can improve the business relationship because once this manual involvement is remote, it means the chances of any errors are remote. So since the errors are remote, your claims are getting patched at a much higher rate. That means the provider groups are getting back the reimbursements at a much faster rate. And in this, in turn, facilitates a good business relationship between the organizations, the provider-payer relationship, and also other covered entities. Enhanced customer service. Since we are removing these, improving the accuracy, that means we'll be having. That means most of the customers are happy, and they would drastically reduce the number of calls that are related to inaccuracy. Increased sales. So obviously, if the customers are happy, like for example, Medicare and Medicaid states are happy, they would give you a larger proportion of their customer base. So because you are now servicing better, right? So that would increase your sales. Minimize the pay-per-use and storage. Obviously, since the manual process, you're avoiding it, all your data is in your electronic format. So that's a big advantage of, avoiding the physical space for storing all your hard copies of the claims. So it's all available in your electronic media and easily available for retrieval purpose. And, in turn, all these benefits, provide increased cash flow. Right, so in a nutshell, this is what an EDI system is. Okay. So talking about more details on this EDI transactions, this EDI transactions is nothing but a set of code sets. That means each and every transaction is in a certain form of electronic format, right? So these help us to standardize the exchange of health-related administrative information. For example, for claims or reimbursements or premium payments, any one of these are actually the transactions. Okay, so what is behind these transactions? How are they governed? What are the rules? So as we talked about in the previous, the exchange of information happens from one system to another system, from one computer system to another without the human involvement. So it's all electronically driven, rule-based transactions that happens between two different organizations. Thirdly, the transaction. So the transaction that we are talking about is an electronic business document. In other words, it's an electronic transaction of each and every encounter or a fact that has taken place between a provider and a payer, or the healthcare service that has been provided by the a physician to a member. So that particular fact is transmitted, and that transmission is in a particular format called a transaction. And we are talking about HIPAA, which is healthcare-related law that provides the data security, data integrity, and privacy of the patients. So the format which we are talking about is your X12, and X12, BSc X12 is the name of the organization or committee that puts together all these standards, and AXM is the number of the transactions, just so everyone is very, very clear on that. Okay. As I said, ASC X12 is the name of the committee that is responsible to come out with these formats, and healthcare is only one domain, and similarly there are other domains in terms of your insurance, in terms of your finance and other sectors too. So ASC X12 is a major organization within the ANSI, American National Standards Institute. Okay. Then successful EDI transmission. When do we call a successful transmission? That means whenever a transaction that leaves a particular organization, their EDI, and then it is successfully transmitted to other receiving organization, a handshake takes place, right? That means when you submit, then you need to receive back an acknowledgement. So the acknowledgement could be like, for example, if it is a fatal error, you get back a status saying there is an error, or if it has passed some basic minimum edits, then you get back an acceptance status. So that is where you call it as a successful transaction. Okay. So the claim submission is in a standard format that is acceptable to both the provider and the payer, number one, and you are sending or receiving the right version of the document. And the claims contain some basic edit information, like for example, the provider and the member information and other validations that happen. So then once it meets this criteria, then we call it as a successful EDI transmission. The reason we are putting all these success criteria here is if you are working under EDI environment, so these are the debugging or a diagnosis you will be performing on the transaction. So it's important that you understand when is a transaction successful? Did the transactions go from our system? What transactions or what acknowledgements we got them back? So you need to track, the sending and the receiving of these transactions every time a batch is sent and received. So it's important these success criteria. Continuing on these HIPAA, we need to know about these HIPAA rules. I mean, we don't have to know the details, but as long as we know that it is related to the healthcare, and it is basically meant to protect the personal healthcare information. And these information is related to the covered entities. We will be seeing the definition of these covered entities, but the HIPAA rule covers all these healthcare entities that gives the patients a list of a bunch of rights with respect to that information. That is where the HIPAA law revolves around. It is to protect the patient's data. And that means the one thing is about the rights, and the second thing is about the privacy. It is balanced so that it permits the disclosure of the personal health information. That means every patient, for example, if I'm working for a company and I have some a severe health an issue, like for example cancer and HIV, and I'm getting treatment outside, my employer does not know the details of the sufferings that I'm having, right? So in that way, it protects you from the information being disclosed to the unauthorized members. The reason is, if the employer comes to know that you are undergoing such a long-term treatment, then he should not use that as an excuse, to either to fire you or move from one area to another area. So that's the reason your privacy has to be maintained. So this HIPAA law will protect you from that kind of situation. Then there's a security rule that specifies a series of administrative, physical, and technical safeguards for all the covered entities. Basically, it will help you to maintain the confidentiality. I mean, whether your healthcare information, about the treatment that you are receiving, about the demographic information, whether this information is floating around within a payer organization or if it is in the payer organization, the complete security has to be maintained about the data, because that information cannot be in a very public area within an organization. It has to be in a proper places, and it need not, and it should not be kind of visibility to other areas, and only the right required people should be able to access that information only on them if there is a necessity to access that information. So that's the reason there are some strict rules who can access that information and under what situation it has to be accessed. So that's the reason the HIPAA rules are related to the rights with respect to the healthcare information, that provides privacy, and also establish the security rules, whenever this information is being handled by different personnel. Okay, so let's talk about, I want to recap, how these, what are the different steps that would take place, before they get into this any claims processing system. It's now important before we get into the more documentation about the technical documentation. Last time we talked about the different steps. So those steps are like, the first file that we receive from a payer or a provider, that contains the claims information. Then it maps into the different fields into the facets. That means the facets has 7 standard of information in order to process the claim. So those fields are mapped into the facet system. And we have seen that the claims are split into a different file, maybe a 1 file or 2 files, depending upon, the different criteria. So we are calling it as an intermediate work file. And it reports, the files are subjected to some edits, and reports are generated at this point of time, and then some intermediate work file is processed to generate the claims. So this is very high level, the way the claims are fed into the system. Then we want to let you know about these different documents that we refer when we go into the workplace. So we very often, refer these documents called companion guide or implementation guide, or it's also called as a PR3, meaning it's the version 3 of the technical report. So let me give you, if you look at the picture here, right, yeah. So this particular picture, we're talking about the companion guide. Companion guide is a specific document that tells you, how do you implement the specific business rules of any particular payer or a provider, right? And at the high level, then you have an implementation guide, IG, or a technical report key, which is published and issued by the CMS. So intern CMS would have outsourced it to another company called WPC, which is called Washington Publishing Company, but they would issue these documents on behalf of CMS. So CMS issues a general high-level guideline, how the transaction should comprise of. That information is available in the IG or implementation guide. Then it issues the companion guide that has very specific details, right? So I want to make sure that you understand between these two set of technical documents. So CG is always a specific, and it has to be used in conjunction with the ID or TRT document. All right. So I will be posting these examples and sample CG and the TRT document in our blog, so you can take a look at it. For example, let me show you while we are here. Okay. So here is a technical TRT technical report here. So it says technical report, EDI and ASX12 standards. ASX12 is the one who has provided the standards, and healthcare claim is an institutional claim, and transaction number is 837. So this is a huge document. It's 610 pages of a document, and look at here, WPC is a publishing company that is authorized to publish and distribute to anybody. So it is not at free. So it is available online, but at a cost. Okay. So any organization that you go, this is the basic document. So I would suggest that you should ask for this document where it is located. And you can, some companies allow you to print it, some may not because of the size. So if you are able to print it in some sections, so you can always print it and refer it. So you would be referring this document on a daily basis. So it's very important that you understand the different sections of this document. And I will we will talk about the different the terms that are used here and how to interpret them. And if you need something, how do you find it? So we will be going through this TR3 document. And also I will show you the CG. I think I have a CG here. Yeah. So this is called a companion guide. This has a more specific details, like it talks about the one particular document element here in the file, what it consists of, whether it's required or situational, and what values it can have, and and expected values. And if you see some unexpected values, it would throw up an error. So it's a very, very detailed document that is provided. All right. So here we go. So this page is a companion guide, and as I said, companion guide is a very specific document, and this has to be used in conjunction with the implementation guide provided by the CMS. All right, we'll go back to our presentation. So I think you all are clear, right? This, because whenever we see a companion guide, you should be able to know that it's a very detailed document that describes the specific requirements. And if it is a TRT document, then you should know that this is a high-level document that is provided by the CMS. Are anyone trying to answer any questions? Okay. I can come back, at when we move on to a different topic here. So don't worry. Okay. So here is a list of a transaction, the EDI transactions that are exchanged between payer or provider and vice versa. Right. So for 867 is a very, very commonly used, for the claims or encounters. Then we use 270 and 271 in order to check for an eligibility inquiry response. So you ask your questions like inquiries on 270, and you get back your responses using the transaction number 271. And if you want to check the status of your billing or a claim, like what has happened, or ask for why it is paid less, and any such things, then there is a separate transaction for that. Which is 276 and 277. And remember, we all talked about the HMO and the authorization. So yes, here is the transaction. If you are seeking referrals for any specialized services, then whenever there is a payment to be made, so you need to use 835 transaction. And if you have to provide some additional information, so for that some attachments, etc. So we got a 275 transaction. So at least you need to know the definition of these transactions, for what for these transactions are used. So in case you have required interviews, so these are the basic questions that you will be asked asked, like, what transactions you have been using it, what is the purpose of it. So this is another tip for your interview questions. So let's go a little bit more detail into the transactions here. The same transactions what we just talked about it, it can be classified like 270, 271, and 278. They're all are transactions prior to the treatment, right? Before even a physician provides any service, or if a member seeks the health service, these transactions are executed. For example, eligibility verification, right? You go and seek an appointment, and then the provider will immediately call the payer, or he would go in online and check the verification, whether you are an eligible, you are an active member, etc. Right? And then if you are seeking any service, eligibility service or some referral, so they will be checking, do you have any referral? Are you authorized? Right? So these are the transactions they are used. Now, once the treatment is provided, then the claims is the one that you bill it, and then you get the reimbursements using 835. Then there are other transactions. They have nothing to do with actually member seeking the healthcare, whether he goes or not. For example, enrollment. Enrollment, for example, I have joined a company, and there is some, for example, there are over a dozen new employees, and my employer will send this information to the insurance company, and the insurance company will send these newly enrolled members to the provider so that it is in their system. So that's how these enrollment transactions are used. Then there's a premium payment. So remember we talked about there's a two types of payments. One is a capitation fee, and the next one is your fee for service. So that kind of a payment is done from the payer to the provider, and the transaction that we use is your 820. And similarly, there's a transaction called 837, which is a claim or an encounter. That means the claim, the fact that a provider has provided the service to the member is what the 837 to bill the payer. These transactions are used, called 837. Okay. There are a couple more terminologies that we need to introduce here because, studying into this healthcare domain, I think it's important we know what do you mean by covered entity, and I want to give you some specific examples here. So we talked about this HIPAA, which revolves around the privacy and safety rules. These apply to the covered entities. This is a group of organizations, in other words. So the covered entity means the one that provides routinely the healthcare information, that handles the healthcare information, they are called the covered entity. That means, for example, it could be health plans, meaning health insurance companies, then healthcare clearing houses, then healthcare providers, like your hospitals, etc., who electronically transmit health information in connection with transactions. That means any organization that transmits healthcare information is called a covered entity, right? So I want to make sure that this definition is clear for you all. So, for example, healthcare providers, I think this should be easy to understand, such as your doctors, physicians, clinics, psychologists, dentists, etc., right? So they all fall under the category of healthcare providers. Then health plans, which is like the HMOs, CPOs, health plans like Medicare, Medicaid, all these are health plans. Basically, they are insurance companies, right? And then healthcare clearinghouse. This includes the entities that process non-standard health information, meaning they get the information from these providers and the payers in any other proprietary standard format, but they in turn convert into the standard format and then they send it. So that's the reason we are saying that they process non-standard health information, but again they convert it and send it. So remember that these medical clearing houses are nothing but aggregators, meaning they send the data and they receive the data, right? And they don't process the claim. In order to process the claim, they send it to the payer. So that's the difference of it. For example, large clearing houses, they process trillions of transactions each and every year. But they actually, to give an analogy, they would essentially perform the role of any post office. That means they receive it, and then send it and pass it on. All healthcare information, right? But they provide a lot of services, not just receiving and sending it. For example, they provide eligibility verification, status checking, remittances reports. So there's a lot of other valuable activities are performed by these healthcare houses. So any questions on this covered education?
Hi, Raghu. What is this HHS mean? Yes, in healthcare provider part.
I'm seeing on the slide. Where is that?
That's like in a healthcare provider, just in connection with a transaction for which HHS has adopted a standard. No, in the bottom.
Okay.
Healthcare provider. Healthcare provider.
Okay, so is it in the last paragraph?
Yeah.
Okay, but only they transmit any information in an electronic form in connection with the transaction for which HHS. HHS is a department, human health services. It is a department of U.S. government.
It has a different standard?
No. HHS is the name of the department of the U.S. government department.
Okay, so if a healthcare provider want to send the claim, then they don't use the EDI?
They will. They have to use EDI transactions. And all these transactions which are adopted or standardized by the HHS. HHS is a very high level department of the U.S. government, and within that there is another sub-department called CMS, which is called Center for Medicare and Medicaid Services. So they are the ones who would adopt and regulate the transactions, the EDI transactions. So all these transactions that are regulated and they would be transmitted, by all these doctors, physicians, psychologists, etc., by these healthcare providers. That's what we are saying. Okay?
Yeah. Thank you.
All right. Okay. So if you notice in each and every session, I'm doing some terminologies, right? So continuing with the glossary of terms, the word invoice and the word claim are mostly synonymously used, but there is a slight difference here. We receive a claim. That means the provider sends the claim, and the payer company in turn, generates the invoice and sends them. But sometimes they are used, for the same meaning. A single paper form, a collection of services by a single billing provider in a single patient bill at a one time. So just so you are thoroughly clear that. The service line and the claim line, they are one and the same. Meaning, if I have a claim, that means there are 4 different services performed on me by a physician. Then each one will be represented in a claim form as a 5 different lines. So these are called claim lines or called service lines. Replacement and adjustment. A billing provider requests to change the previously submitted claim. That means there's a minor modifications to the previously sent claim is sometimes called a replacement. Even though we say a replacement, theoretically it's fully replacing the old, but these terms are synonymously used in the industry. So it also means adjustment sometimes. And there's another word called void or a cancel or adjustment. That means the billing provider requests to void a previously submitted claim. When you say void or cancel, it's very, very clear, but sometimes they also use in a very generic format called adjustment, which would also mean that to void the previously submitted claim. Healthcare claim adjustment, I think there is no confusion here. That means the difference between the billing providers, the amount the provider is billing and the amount that the insurance company is paying, that difference is normally, you are indicating that difference as an healthcare claim adjustment, and which is supported by a reason code always, like what is the reason for which there is a difference. The subscriber and the recipient beneficiary. These are the individuals who are enrolled in Medicaid Even though we are saying Medicaid, it also covers Medicare who receives the services, right? So they are the one like a policyholder or a subscriber or a major recipient or a beneficiary. Then bill to provider or pay to provider or a provider, we always talk, which means it's in hospital or a physician's nursing facility, etc. For whom these costs actually reimbursed. Okay, so just so you are familiar with these terms. So in some companies might use different terms, but they mean same thing. So now we'll move on into the transactions, how these transactions are comprised of. If you take any EDI transaction, whether it is a claims or a premium payment or an enrollment, the way this EDI transaction is comprised of, like it has a loop, it has a segment, it has a data element, then sometimes it can have a composite data element. That means the group of elements put together is called a composite data element. Then these elements are separated. I'll show you an example because that would give you a more clarity on it. And then there are some qualifiers. Then there are some qualifiers, that will indicate, what is the type of a data it is. All right. So let me show you an example quickly on this. Okay. Okay. And I'll try to enlarge the format here. So this is a typical transaction here. This is FT stands for transaction set. That means each and every line in a file is called a segment. And the first two letters or characters, they identify the name of the segment. Then the rest of the information that belongs to the particular segment. For example, here ST is the name of the segment, 835 is the name of the transaction, and some number here, right? So there is always a name of the transaction followed by the number. And then if you see here, there is an asterisk here. Between two elements, there is an asterisk. Between ST and 835, there is an asterisk. And similarly, between 835 and 1234, there is an asterisk. This asterisk is a delimiter. That means sometimes you have seen a comma delimited file, right? That Excel document, each and every cell is separated by a comma. So similarly here, the transactions are separated by an asterisk. And each line is ended with like a carriage return. For example, if you see here the sleeping S, it's called tilde, TILDE. So this symbol, like after the 4 or after the S, after each and every line. So this is the basic structure of a file. So just so you know. Okay, so we'll go back to our slides. See, we talked about the different transactions, right? So just to give you a better understanding, how these transactions flows. So I've given you two boxes here. Basically, it tells you the billing provider, and on the left side, which is your healthcare provider, the one who does billing, and then on the right side, I'm saying the payers. So one side is your healthcare provider, like an hospital, or the right side is a payer, like your insurance company. So let's see what type of an activity will happen between these two organizations, right? So first, let me pull this. Right. For example, if you see the 8 transaction, so it's always generated by a billing provider. That means your healthcare provider, right? So they were the ones who generate the 8 claim transaction. Then it goes to the payers. And the payers are the ones who would adjudicate. That means you would process the claim. And if the claim is successfully adjudicated, if it is passed, they think that whatever the amount that has been billed and charged is actually reimbursable, then they would send the same claim back to the provider, but in the form of 835 transactions, right? So that's how the information flows. And similarly, if there is a status that needs to be checked by the billing, by the billing provider, he would generate a 277 transaction, send it to the payer, and the payer would review the status of 276, and based upon the comments, then he would send back the status report called 277, the claim status report. So that's how, I've listed here only few just to give you a basic understanding. And for example, if there is an enrollment, so enrollment will be generated by the payer and sending to the billing provider, right? That's how it happens. And if it is a payment, a premium payment, payment is always generated by the payer and comes to the billing provider. So that's how it is. Any questions on this picture? So this should give you a good an idea of who generates each and every transaction and where it ends up. So I think you should have the flow of these transactions, good understanding. All right. So we have been talking about the HIPAA regulated transactions. We know that, and we know that ESC is an organization. It's in a committee that would put together all these different formats, set the standards basically. And what are the claims that comes under this particular transactions and the version that we are talking about. The version we are talking about is 4010, which is currently in practice. And they come next year, it is a 5010 transaction. So under these transactions, these are the claims that are impacted right now. So the professional claims, the institutional claims, and the dental claims. Okay. For NCTDP, which is called your pharmaceutical claims or the drug claims, it has got a different version. That's the reason it's not mentioned here. So, but the three types of claims that falls under 4010 are your professional, institutional claims, and the dental claims. Professional claims are that, like, if you go and visit to any particular physician, like an office visit or a general checkup, that's where the type of billing that you would do is called a professional claim. And if you go to any hospital due to some emergency and it needs some hospitalization for a couple of days, and the claims that a hospital would generate for you because you got admitted there, it's called institution or a facility claims. And the dental is the one that, any dental visit you would do that falls under the category of dental. And sometimes the services provided by the dental can also be under the professional. All right? Okay. Yeah, looks like caller 3 has a question. Go ahead. So you don't have any question, right? Okay. So let's see the standard format for electronic transfer. That means the data that we will be talking about is your claims data, the replacement or a void that would happen, the adjustments, and the encounter data. Right? So what are the different types of claims? We talked about it before, but we listed it here again. The claims the services that would fall under the professional, like your practitioners, physicians, ambulance services, clinicals or your labs, radiology, etc. DME means durable medical equipment. So any medical equipment that you use for your purchasing falls under this DME claims. The hearing aids, the dealers, the supplies, any services that are for your hearing and speech and orthodontist, etc. They fall under the professional. Then for your inpatient hospitals, outpatient hospitals, long-term care, home health, skilled nursing facility, etc. They all come under institutional claims, and your dental clinics come under dental claims. So it's quite obvious here. Okay. This information that I'm trying to, before we jump into the transactions, so we want to let you know there are three critical information that are common, that like when you receive a transaction, for example, a claim from a provider, it consists of patient control number, it consists of a patient account number, and also a medical record number. That is also again replicated back in the claim when it goes back to the provider. Basically, they want to tie back the claim when they receive it so that they can track for their internal purposes. Because if you look into the hospital environment, the claims or any transactions or any critical information, it's basically a unique information, unique identified information is your patient control number. And sometimes they have a patient account number. That anybody, for every patient, for his visit or for getting admitted into the hospital, an account number is generated, and that is called your patient account number. So this account number remains the same even though you come next time, third time, fourth visit, or nth number of visits. It does not change. And for each member or patient, So all is medical records purposes. A medical record number is assigned. So again, this is a unique number. So in each and every hospital maintains it, and that number is tied to your patient account number. And from the finance point of view, every member is assigned a patient control number. So these three pieces of information, they kind of again apply into the remittance advice when it sends back to the provider. So that's the reason listed here, so you know what information comes back and what information, in order to tie back the same information, the claim number they have sent. These three pieces of information are used again. Okay. So the different components of the structure of a transaction is in terms of these three types of information. Like for example, it has a submitter information, a receiver information. That means who is submitting the claim and who will receive the claim, who is the provider where the services have been provided, right? Sometimes it might be the same, like a submitter and the provider, or sometimes it could be the different, right? The submitter is your billing provider. He's the one who is generating the claim. So he could be in a different state, and the actual provider could be in another state. So that's the reason it is shown as a two different pieces of information. Then the subscriber and the patient. Again, the subscriber is the one who is the policy holder, and the patient could be his dependents, etc. And the claim is a piece of information in the transaction. Each claim can have a multiple service lines, so the detail lines. Then there is another information called coordination of benefits, wherever there is multiple insurance companies that are involved, and in order to adjust the claim amount by the different insurance companies, the CAB information needs to be furnished. So these are the 6 critical pieces of information that comprises of a transaction. Okay. So this picture was the exhibit. What you're looking is this is how transaction is organized. For example, on the outside of it, it's called interchange control, ISA segment. Okay, and within that there's a Hi Aparna, I think you have a question here. So let me go back to the COB here. See, COB is a coordination of benefits, right? For example, if I am here and I have an insurance company from a Blue Cross, for example, and I have my wife that she has insurance from Aetna, for example. So these two, one is a primary and another one is a secondary. So if I have a claim, and if my total amount is not adjudicated by my primary insurance company, for example, Blue Cross, then the remaining amount is sent to another payer, which is Aetna here. That means the secondary payer is sent the remaining amount, and they would adjudicate the remaining amount. That means when I am a member, my complete amount is paid now, right? So that's the reason when there are two payers are involved, the coordination of benefits, how the adjustments have to be processed. In order to process those information, we need the information of the other insurance company. It's called OHI. So once you provide that OHI, the remaining balanced amount, the insurance company A will send automatically to the insurance company B. So we don't have to do anything. So that is called the coordination of benefits. Okay? All right. So this picture kind of showing us how the different segments are within the loop, right? So if we go back, for example, here, if I let us talk through some the inner details, like segment details, right? This is where the claim information will be there. So that means the inner, your service lines, and right, and then your transaction set. The transaction set is at your billing provider. Like for example, I am one particular hospital called Henry Ford Hospital, right? So all the claims pertaining to this one particular provider is organized into a segment. That means the header and a trailer, SP and ST, within that is one billing provider. All the claims are here. If there is another hospital, for example, John Hopkins Hospital, then all such claims are within the another segment called ST and ST. If there is another hospital, then it will be under another detailed segment between ST and SE, right? So that is how the different segments are put together. And you might be wondering why there are all such different house claims. Think about a clearinghouse. Clearinghouse is the one who gathers all these claims from different providers, different hospitals, physicians, clinics, right? And they are the ones who aggregates all the information and sends it to the insurance companies. And for example, if the glucose is received from different hospitals, that's how the claims will be organized. For example, this will be the provider A, this will be the hospital B, and this will be the hospital C. So it got a header, it got a trailer. That means the header trailer will have like amounts, sum of amounts, and some of the claims. So just on header, so it matches up. That's how we cross-check if the information contained in the detailed segment is matching or not. Then at a one level higher, it's called a group header. So some group level information. And then the third level of outer loop is called your communication envelope, right? So that's how, that means communication envelope will have some, who is the sending, who is receiving, some control segments it will have. So we will go through those segments in detail. But this is how the claim information or transaction structure is organized. So this information is provided in the TR3 document. Which, yeah, tell me the question.
Hi, Ram.
Yeah. What question you have?
It is the
Sorry, your voice was breaking up. I couldn't get your question.
Hello?
Yeah, now it's good.
My question is like, is it okay? Is the structure of EDI or regression?
Each of them?
This structure is of validation engine or it's a EDI?
It's an EDI transaction. So everything that we're talking today is EDI transaction.
Okay, because like it's splitting different segments of the service. Like I was a little bit confused.
Sorry, your voice was not clear. So what I understand is that these transactions are EDI. I mean, whether it is a 837 transaction, whether it is a 834, any EDI transaction, this is the structure that it contains. So it has an ISA segment, which is interchange control header, that tells when you interchange, the sender, the provider, their information is available. The group header is that tells about some more details about the specific transaction that we will be using it, right? And then the transaction set header, which talks about the provider, the details, and all. And then there are the claim level information within the transaction set. So that's how it comprises of. So whether it is an 837, which is an 884, but the structure is same. So these are the EDA transactions. Okay. Okay, so let us move forward. So a little bit, it's a little bit more graphics here. For example, we talked about ST, that means the transaction set. That means it consists of header and a trailer, right? So a header information and a trailer information. And if there is another billing provider, this particular header and trailer, it repeats. So, okay, and then within that, there's a functional group header. Like, for example, any organization, even though this can repeat multiple times, mostly I have seen that it only occurs once. So just for convenience sake, they want to repeat only once. And if it is having more, then they would send in a different file. And always ISA is only once. It can't occur multiple times. ISA segment is a header level, and then IEA is at the interchange level, trailer level. Okay. Okay. So now we will talk about each and every loop here. So we will go very detailed enough. So this information is a little bit of a technical. So if you go as a BA, we will certainly need to know the structure of a transaction. So pay a little more detailed focus on what we talked about today because it's very, very critical. And, as a BA, I think this will be used anyway, whether you are on a product or an administration, or if you are on a claims, or if you are on a data warehousing, any healthcare organization, these transactions are used anyway. So you have to deal with it. So this is very, very critical that you really understand thoroughly. So the first information, among the 6 pieces of information that comprises of a transaction, we said submitter and receiver information is one of the information. So that information, what it contains? So it contains like entity type. Okay. Then it contains the primary identification number. So I'm talking about entity type. That means is it a person or is it in a facility? Then the contact name. Then the community contact information, right? Like a fax number or a phone number, then exchange, that kind of information. As we are capturing submitter information, similarly we need to capture the receiver information. Who is receiving it? What is the receiver ID? This receiver ID is okay, and the primary IDs, these are the ones that needs to be provided by the CMS. So these are the standard IDs. Okay. So let's see an example of that. Remember, look at this number here. Every element here has a number. For example, the submitter information is always available at 1000A, and the receiver information is always available at 1000B. So in the example, let's observe that one. So here is an example, the receiver information, and the top one is your sender information, and the bottom one is your receiver information. Okay. So if you look at this, NM1 is a segment name, PER is a segment name, NM1 is a segment name. Always every line in a transaction starts with a segment name, and the remaining ones are a sub-element. That means the details of that particular segment. So this is the name. So name, who has submitted this. So this data is coming from a clearinghouse, for example. Okay, and then the contact name. Now who is sending? Sally Smith. Okay, and who is receiving? So this is a NBCH Medicaid fee for service. They are the receiving one. So this is in general how the transaction looks like. Okay, so the submitter is very clearly here. Then the receiver, okay, and the contact name. So that's how these 1000 and 1000A and 1000B are listed here. Those loop numbers are never in the transaction, but it's only for our understanding. And if you look into any technical documentation, it will be by this 1000, 2000, 3000, etc. Okay. Let's see another example here. The billing provider. We have seen the submitter, and now let us see the billing provider here. So billing provider information, again, if you look into this loops here, you say, right, the billing provider can be multiple times. So one such billing provider has a billing provider name, his address, zip, if there is a secondary identification number, his details, the billing details, if whom it has to be paid, the name, the address, etc. So basically, this consists of name, address, some identification number, employee identification number or SSN, and then the Medicaid provider number or a Medicare provider number. These are the ones generated by the either states or from the CMS. So these informations are populated under the lines called 2000A, 2000AA, and 2000AB. Okay. So 1000A was the receiver and the sender. 2000 series is under the billing provider. So as we keep on looking at the claims, we get really familiarized, by these numbers and what type of information it contains. Okay. So I want to give you last time we have seen a sample form of how a claim looks like, right? So this is another, the red color that you see on the top here, from here to here, this is a sample form. So on the form, what you're seeing is your tax ID of a claim, who is generating it. the physician name is here, and the physician address is here, right? And the PIN number is here, the unique identification number. And to see how it goes into a transaction, so that's what is given here at this bottom here. For example, here, the name of the physician, the address is here, okay, and their identification number is here. This is here their identification number or federal ID, okay. So just to give an analogy of how from the paper format into an electronic format, how the billing address is translated, okay.
Hi Raghu. I have one quick question. There are some places there are asterisk, some places there are some to like basically how it's defined.
How it is defined? So the billing address is it is always defined, at the 2000. 2000 is the name of the loop, so that's where the billing addresses are defined. So every claim has to be a billing provider address. So it's a very, very mandatory information. Okay. So is that what
I'm talking about the asterisk. I'm talking about the asterisk because like NM1 S85, but there are 4 asterisks somewhere, 2 asterisks.
Oh, the asterisk part, the star in between.
Yeah.
Okay.
Yeah. So like, is it?
Yeah. Let's
logical way, like how they are.
Right. Oh, for example, okay, I think it's I wanted to show the ER3 document at a later stage, but let me show the document now so that it would clarify you. All right, so on the right hand side is the TR3 document I have opened. And for example, if you see the billing provider address here, you can go up. I'm scrolling down to the billing provider so that I can correlate and let you know how these elements are separated. I'm finding the billing providers here, for example. Subscribers here. Okay, the billing provider is the NM1 here, the payer name. Is it too small? Let me magnify a little bit. Okay. See the transaction here, NM1 PR. See the transaction here, for example. So if you see that PR2 ABC, that's an insurance company here, okay. And if you see the structure here, that means 1, 2, 3, 4, 5, 6, 6 plus 6, 12. There are 12 elements here in the segment NM1, okay. Each box represents one element. So each element is separated by an asterisk. If you see here, you can see an asterisk, right? That's what this asterisk is, okay? And for example, if you see there are some three boxes here on the top and there are three boxes at the bottom. They are striked off, right? That means they are not used now. If you are not using it, you will not fill any data here. For example, there is an asterisk here followed by an asterisk, asterisk, right? So these asterisks, if there is no data involved, you will not enter any data, but just use the asterisk so that you can tell that the next element is used here. So that's how the significance of asterisk is. Did you understand the significance?
Yes.
There?
Yes, Raghu. Yes, Raghu.
Okay, all right. So this document I will post it in the blog, so you can then you can really correlate and see each and every example here. For example, this is NM1, right? And similarly, you can see the entry. So let us go down and see the entry here. Okay, so the pair address is here. Okay, so the entry is right here. So this is what the entry is. So each and every element will be shown in the TRC document, like how it has to be used. Okay. All right. So we'll go back to our slide here. This is another example, just to correlate between the manual form versus electronic format. The billing address is right here, the facility, the Miller Nursing facility here, and also the tax ID. This comes to your tax ID. Then the entry, import. So entry is always like your street address, and then the city, followed by the state and the zip code. The reference identification number, 601, etc. So the provider unique identification number. Okay. Then the Miller Nursing Home, this is the name of the facility. Okay. The contact information basically. Okay. Some more details that I have provided here, just to see what the integer segment is here. So for example, the name segment here, 85, or this is element number 2. The NM1 is a segment number 1, and 85 is your segment number 2. It means the billing provider. So there are different values that it has. So TRC document provides us what these values are. And then 1 is your person, and 2 is for a non-entity. That means if it's an hospital, then you put it as a 2. But if there is only one physician, like single physician operated, then it would have the value 1. If it is a 1 here, then you'll have the name of the person. And if there is a 2 here, then you will have name of the facility here. So that's how the data integrity is maintained. Okay. So here again, this particular element here, it is a tax information, tax ID. So that's what will tell you the number followed is meant by EIN. And then entry is very easy to understand here, the street address. N4 is your city, and then your identification number, the medical provider number. Okay. So do you all understand how the transactions are built here? So we have seen the submitter ID, the receiver ID, and now this is your billing information. Okay. So let's move on to the subscriber and patient information. Okay. So the loops that are provided to capture the subscriber and patient information is your 2000 series, that is 2010 DA, which is your subscriber name information. So similarly, so always the names are with NM1, N3, N4, so that it is consistently used in the transactions. So the name, the address, the beneficiary, the ID, the gender, and the date of birth. Okay. So for your example here, the name includes the beneficiary across all the claim times. So which would be the arithmetically they would maintain. NX is like N3 and N4, and the demographic information, date of birth and gender. Okay. So as an example here, if you see, the name of the patient is John, right? I mean, Doe John. So that's how it will be represented in the transaction. Is the first name and then the last name. So, and then MI is your member ID. That means then it's like qualifiers here. MI is like your qualifiers. When it tells you what type of information is followed the next in the next field or a next element. So field and element are synonymously used in these transactions. So some people call as a field and some call as in a segment here. Okay. And so the N3 and N4 is the address of this subscriber, where he lives, and then the demographic information is here. D8. D is for your date, and 8 is for that means it contains 8. The length of the data field is 8. For example, in some places wherever there is a range, there is a different is used. That means DR8 is used. Okay. So any questions so far? The pieces of information that we are seeing. That means I'm drawing an analogy how the information would be filled in if there is a paper claim, and the same claim information if you are sending in an electronic, how the data would be represented. So we have seen the submitter, receiver information, we have seen the billing information, now we have seen the subscriber information. So once you put in electronic and when you compare it to a paper format, it makes sense actually, so that you know from which section the information is coming and falling under the electronic transactions. Okay, so next, level of information that we want to talk about is the claim level information. So what does the claim level information have? See, it has a claim number. It's critical. That is a unique number that the facets will generate. Then there's a patient control number. Remember, we talked about patient control number. We talked about medical record number and patient account number. These are the ones that we get from the provider, and we again send them back in the claims information. So there is some claims charges here. That means per claim, how much the provider is billing, and the claims frequency type, etc. Medical record number. So the difference is, the claims can be different, right? I mean, there can be a repetition of claims. But what is the difference? That means a different base, basically. That means I visited the doctor multiple times, and every time, I visited, he generated a claim for me. So that's the reason, there could be a date and a different type of a claims here. So this claim information, as we mentioned before, like for example, professional claims, we have a patient account number, diagnosis information, and total charge. So these pieces of information are under the professional claim. And if it is institution claims, basically this slide is telling you what are the different pieces of information that are specific to the professional claim. What are the information that is specific to institution claim? And then what is the specific information that is to the dental claims? Okay. And the information that is highlighted is very common here. That means from type of a claim, it is the same information. That's the reason I highlighted that. So for institution claim, let us see what information it is. Patient control number, there's a unique identification number. Type of a bill here. That means based upon the reason code, the CMS came up with a type of a bill. So it's basically some standard 2-digit codes. Then the statement date, when they have generated the statements. Like for example, if I'm hospitalized for about 1 week, then from that first day of the week to the last day of the week, that would be the statement date. The patient status, that means am I still, I don't know what condition I was. Medical record number, simply a number. Principal procedure codes. So remember we have talked about those CPT codes and HCPT codes. So these codes that we need to put here. The condition codes, then the occurrence codes. So there's a different type of codes. There's a provision, for these institution claims. Then there's a value code. Then there's a total charge. That means for this particular claim level. So since we're talking about the claim level information, so the charges that are appearing on the claim, which is nothing but the sum of all the line level information is your total charges. Okay. The diagnosis, the ICD codes, the attending provider, who is the physician who has provided the service. So all this information will appear for institutional claims. And for the dental here, and if you see there's something specific to dental, right? Like, for your teeth, for your orthodontics, so that kind of information. Okay. So this information that what we are seeing right now is specific to the claim level information. Okay. See your PLM. PLM means it's a claim. Okay, and then what follows after the CLM is your claim number information, and then this is a charge amount. Okay, so now let us see here, for example, patient control number, which is your CA ID. So this is your CA ID. In some companies call this a claim control, patient control number, and some companies refer to the claim number. So don't get confused here. And then this is your amount they are charging it. So right here, this is a 3,000 here, and there's a decimal period here. So it's not 300,000, but just a 3,000. Okay. Then if you see the date here, date is your 430 is the type of the date here. And here, whenever there's a range, remember, it will be RD8, and only one date is mentioned, means it will be D8. So that's how you need to look into it. Okay. Then there's a health information here, like an ICD code, the quantity, that means there's an adjustment of $30, and the name here, Smith John. Okay, the attending provider, his number, and the name is right here. Okay, so it's clearly, you can translate the manual format into your electronic format and see how this information is. Any questions on this claim level information? When you compare, it should be obvious, where these charges are coming up in an electronic format, basically.
Raghu, this is right.
Tell me.
Yeah, now I have a question like this. Reference codes, what you are mentioning and showing as an example, all are these referred with the documentation process by ASC?
ASC is the one company that provides such a documentation, and it provides the services also. And similarly, HP is also another company that provides the documentation and that provides the services. For example, on the Medicaid part of it, it operates in several states, and also on the Medicare also it provides the services. So these documentation is provided by the companies like ASC and HP. Yes.
Okay, because EDI process as such, irrespective of software, that is both behind the scenes as well as front end, it has to communicate, even if the softwares are different, right? So in that way, this codes must be of uniform processes, right? So it has to be developed by some standard company or some government agency.
Yes, the basic documents which I showed you, like a TR3 document or implementation guide, they are the ones published by the CMS, by the Federal Health HHS Department, and they have actually outsourced that publishing work to a company called WPC, Washington Publishing Company. So based upon that TR3 document, these individual states and clearinghouses like ACS and HP, then they come out with a specific companion guide. They call it a companion guide that is specific to the state. Like, for example, if they are providing services to Texas, then they would come out with a specific document. So these specific CG or companion guide would be in line with the corporate or central government's technical report document. Okay, so there would not be any contradictory, but it would be in line with that. It's a little bit more specific to the requirements, basically. But the structure-wise it will be the same, the format will be the same and consistent, no matter whichever tool we are using and whichever EDA software we are using. The purpose is same, and they should be compatible to receive and send any EDA transaction.
Got it. Thank you.
So here is an example of a claim, what we have just seen, the claim level, the different dates here, the ICD codes are here, that means the series of codes are here, the quantity, okay, and the name of the physician, then the identification number. So once you break it up, so the transaction does not look complicated, but without knowing what the individuals are, and if you look at the file, then it would really appear to be complicated. But if you break it up into your claim level information, into your billing provider information, into your subscriber information, the receiver sender information, it would actually look simpler. So that's what I would do it, if I were to test any claims. Okay. So now let's talk about this service line information. We have seen the claim level information in the previous slide. So now we will talk about the service line information. Service lines are the number of different services provided by the physician, right? So basically what it contains, it would contain the quantity, right? I mean the medicines or the number of days in which he was admitted, the charges for that particular service, what are the service codes, like a CPT codes or a HIPC codes that we talked about it. That means the specific reason, the services your physician has provided. It could be your medical, it could be your surgical, or the diagnostic codes, right? Or it could be your HIPC codes. And then the different dates of services. So these are the components of the services information. And each and every service, you will find a code like SV1, SV2, and SV3. SV1 is for your professional claims, SV2 is for your institutional claims, and SV3 is your dental claims. So in order to differentiate, they came up with SV1, SV2, and SV3. So remember that. It's not that there's a service line 1, service line 2, and service line 3. So it's not like that. So SV1, I'm repeating, SV1 is for professional claims. SV2, the letters SV2 is actually used to represent a facility claims, and SV3 for dental claims. Okay. And on the right side, given two figures here. The first one is your diagnostic code. That's how it appears on your manual format. It has a provision of the 4 diagnostic codes. And then the picture below is your CPT and HIPC codes. And next to the HIPC code, what you're seeing here is your diagnostic code pointer. That means the HIPC code of 98940 is actually related to diagnostic codes of 1 and 2, like 73.1 and 79.1. That's what it tells. Okay, so let's go into the details of the service lines. Here it is. The service lines, so these are the ones for professional claims. So you would see this is procedure codes. You would see the date of service. Then you would see the place of service because where the service has been provided. Then the diagnosis pointer. Then there's an emergency indicator. That means was your visit under normal situations or was it an emergency situation? Because it is an emergency situation, the rates are different. Who is the other provider information, and the referral information, and your adjudication payer line information. So these are the pieces of information that fall under the professional claims. And under the institution claims, you will be the revenue code because the revenue code is different. If you are like a regular bed room or if you're in a luxury room, what kind of services were provided, the date of services, the service units in terms of quantity, then the procedure charges, so etc. And for dental, there's a code called CDT. Remember, CPT and the HIPC codes are for a professional institutional, but for a dental, they call it as a CDT codes. Then the tooth number, the surface, and etc. So these are the pieces of line level information we are talking about here that are under the different types of claims. Okay. All right. So let's see the example here. So always showing an example would give a better understanding here. So these are the two different lines in this example. So line 1, it has a date here, like 8/15/2001 to 8/15, that means on a single day. And then on 8/22, there were 2 visits have been made, so 2 different services. And code they have used is 99201 and 99213. Diagnostic codes, that means ICD codes pointers are 1 and 2. The charge, $5,000 was charged on day 1, and the second day there was $1,000. Number of days, which is just 1 day. And first day was an emergency situation, and then there was a normal situation. So let's see how it is represented in terms of this electronic format. So since there are 2 lines here, then we got LX1 and LX2, right? So that's simple here. Then service SV1. Remember SV1, SV2, SV3, I said SV1 is for professional, SV2 is for institutional, okay? And SC is your healthcare procedure codes are represented by SC:99201. So that's the convention, okay? And here 50 is your charges. That means for the first time they charge $50 and the second one they charge $100. Okay, the UN stands for units and the number of units, which is 1. And what is this 11 here? It's a place of service. Let me show you an example of place of service. So, okay. So this document will tell you the different place of service. It's a 2-digit code, basically. The name of the service, for example, 01 is like your pharmacy. 03, that if you are ill, fell, then at a school, then the 03 is used. And, if a patient has fallen ill in a homeless shelter, 04 is used. And if you scroll down here, you can see, like for example, office means it's 11. If it's at home, it is 12. So these are the standard codes, provided by the federal agencies. If you go to an urgent care, then there is a place of service is 20. Because based on these service codes, then they would do a revenue code, for that particular charge. So it's so important that, these codes are represented accurately. If you visit an inpatient, as an inpatient, then there's a 21. If it's an outpatient, there's a 22. All right, so, okay, and so on here. Okay, so that's just for your information. All right, so we have seen this 11 is a place of service. I'm not sure what it is, 1 and Y here. Y is your emergency situation. Okay. And the diagnostic codes, 1 and 2, the pointers, basically, these are the pointers, so the 1 and 2. So it's very simple here, if you translate the claim information into electronic format. And here the date is given here. Okay. All right, so this is another example here, room and board, that means there is institutional claim. He got admitted here for a particular day. The rates are, $100 here, 100. The unit is 30, and another example it is 100 here, but in this example, and $300 here. Okay, so this is $300. And there is a revenue code is 0120. It's 120 is a revenue code here. Okay. So the rate is based upon the revenue codes, and we normally do see the description here. The room and board is a place of service. Okay. Okay. So another service line for your dental here. So there's a date on which the service was made, 2/15/2002. See here SP3, it's not SP1, SP2, it's a different code they have used. So for the service line, tooth and the surface. So here is a tooth and the surface here at the bottom. Then there's a procedure code 2140. So 2140 is used here. This is a charge of $29 and the unit. So this is how a dental claim service line would be represented in an EDI transaction. All right. So that was the claim level information. So now we will see the COB information, which is, we said in case there is a multiple insurances are involved, then there should be a COB information. So what does this COB information have? Basically, it has information about other insurance company, right? So who is the payer? Then the adjudication information for that particular insurance company, and how much we are actually charging the other insurance company to adjudicate, how much of a paid unit, and the service line adjustments. So these COB information is at the service line, and also at the claim level information, we will be telling about the COB information, the claim adjustment, the insured's name, the amount, the benefits, the patient's signature indicator, some claim level information. Okay. This picture, I want to give you a little bit more understanding. When a COB is involved, how does the information flow between a provider and a multiple insurance company? So let us take a simple example. For example, I have a claim and I'm at a hospital there is only one claim, and see here the first claim, assume that we are sending to a Blue Cross insurance company. They would process that claim and assume there is no other insurance company, there is no COB, and I would get back the remittance back to the provider, right? That means HX by transaction is a remittance, the cost reimbursement from the payer A. So one loop, we are sending it and we are receiving it, which is good. It's a simple, happy path. So now let us assume there is another situation where there's an underpayer is involved. So we'll be sending the information, the claim information to the payer A, and he will be paying, for example, like a 60% of the cost. Then for the 40% of the cost, then he will be sending to the payer B, yeah, at the bottom. The claim has been reformatted to place the payer B information, right? That means in the claim information, there is a placeholder to put who is the secondary payer. So that information will be putting into the claim, and that claim is resent to the secondary payer. That means the payer A will send the claim to the, will be sending the 837 claim to the payer B. So the payer B will now undergo the adjudication process, and he will process only for the portion for the which he has been sent from the payer A. And then the information will be coming back to the provider. So that's how the loop goes on. So first from the payer, from the provider, the claim comes to the payer A, and portion of the claim is processed by the payer A and he reimburses, and the remaining portion is sent to the secondary payer, and the secondary payer adjudicates the claim and he pays the remaining portion, and he would send the remaining 835 remittance back to the provider. So I think this should give you the cycle, how the COD is and how the COD information, loops around between the multiple payers. Okay. So having seen the different sections of an EDI transaction, there are some limitations, like how many claims it can have, how many loops it can have, how many repetitions it can have, okay? And it depends upon, from organization to organization. And, if it is a Medicare, you have certain limits, and if it is a Medicaid, you have certain limits. So it's up to the insurance companies, how they want to, regulate them. But generally, the one which is provided as per the guidelines, is up to 5,000 claim segments, right, in a single transaction, that means in a single file. Up to a maximum of 100 repetitions of 2,300 CLM loops, right? That means it's a claim. Then the 50 service lines, the individual line item, so 50 for a professional and dental claim, and 50 or services for each institution claim. So these are the different guidelines that you need to know. And these are not the interview questions, but in case you are checking for a claim, to see if there are any errors before you actually send it out. And if they reach these threshold limits, so it's better you catch them and send the remaining in a different file. Okay. So in the beginning, I have showed you the structure of the claims, right? Like an ISA segment, the GSA segment, which is a functional group header. ISA is your interchange control header. So this is how it is represented, right, in the claim levels. For example, let us talk about from the detail level, inside out. So 2400 is your number. This is a loop number. Basically, it has your service line. So it can have a multiple service line. So all we are saying is, per claim will have a multiple service line, right? So at the billing provider level, we will have, at the subscriber level, we'll have a multiple 2000 Bs. That means there could be a multiple subscribers. But as a billing provider, there could be one billing provider and several members here. And at the one more higher level, even though we are not showing here, there could be several billing providers. That means there could be a 2000A for billing provider 1, then 2000A for a billing provider, which is another hospital. So in that way, these loops repeat. So any questions on this? This is a good picture, helps you understand which loops repeat. So it's important because when you see a file, you need to know, okay, this particular hospital is repeating 4 times, 5 times, and at each hospital there are multiple subscribers. That means there are multiple patients here, and each patient is having like a 40 claims, 50 claims, and each and every claim has like a 5 lines, 2 lines, 10 lines, etc. So it gives you an understanding how the EDA transaction is structured. So far we talked about the claims. So the claims are generated by the provider, and the claims are received by the payer. And now, once the claims are processed and the remittances are paid by the payer to the provider, then there is another activity that is done by the payer, or it is done by the clearing houses. They have to report this claim information back to the federal agencies or the state agencies. So the process of reporting that claim information is called encounter data process. Okay, so this is the second activity after the claim has been processed. So what happens in this encounter data process here? So let me walk you through this exhibit. The MA organization, that means managed care organizations, are the ones who would be submitting this information. Okay. So what level of information? The HIPAA 4010 or a 5010 they would be submitting. To whom they would be submitting here? They would be submitting to the CMS. CMS has a software, it's a commercially off the shelf, COPS software. It's called EDFES. It's just the name of the software they are implementing it. So it is this software that receives the HIPAA 5010 transactions. Currently it is 4010 and the next year it will be 5010. But what is listed in this bullet is important for you to understand what they are trying to do with these transactions. These transactions, that means the encounter information, would be subjected to some front-end edits, they call it. So they would be reviewing the institution claims, they would be reviewing the professional claims, the DME claims, the dental claims, etc. And some edits are performed, like common edit modules. And then there's the interchange modules, basically to check the format level errors. Okay. Once they have this first basic level errors, then there's a second level of errors that they would look into it. And at that point of time, they'll be looking into this ICD codes, procedure code, place of service to make sure the right amount of pricing is done. Okay. And what happens at these levels, level 1 and level 2, if there are issues? So what I'm listing on the right side is what those status reports are generated if there are any issues. So technical report 3, right? This is a piece of a documentation in which we need to refer to the details of it. But there are some status requests, 276, 277 also. When you send this information to CMS, they would send it back to the payer about the receipt of this information. Okay. Okay. So this is a little bit more detailed, like what goes into these transactions. Okay. So let me walk you through again. We said there are 2 levels of edits that happens, right? That means first level is your interchange level, and the second level is at the claim detail level, where the business rules are checked. Okay. So first here, if you look at the very first level of check, that means interchange envelope confirmance and acknowledgements. They would be looking into the interchange confirmation header. That is, the payer information is right, the receiver information is right, because they are the ones who will be giving these IDs, right? So the plan IDs, for example, they have to match. So if it is not matched, it will generate an error right away. That error is called TA1. It's called TA1 interchange acknowledgement for ISA. If these edits pass, then it's fine. They would go to the next level of edits. So the next level of edit is called 999 process. That means it would check for the conformance of the standard, external standard. Is it as per the standard? The ISPA number, the field, the delimiters, etc. And if it fails at this point of second level of editing, they generate a report called 999. Simply it's 39, that's the name of the error report, and the providers or the payers or the clearing houses would automatically get this report. So first level of error report is called PA1, second level of error report is called 999. Okay, so this is another level of 999. If the implementation guide conformance is not in compliance, then there would be an error report called 999. Then at the third or fourth level of validation, the actual claim level information is actually validated, and if there is an error, it would be shown in this transaction. If there is no error, even then we'll be getting this two terms from CA. It's a claim acknowledgement report. So just so you know, it is very good for your interview purpose. So you can tell that, the claim level information and that encounter level information and what are the acknowledgements that you get. So the acknowledgements are the clear one, which is at the interchange level errors, and the 999 error report, which is at the standard textual standard conformance level information or implementation guide conformance errors. Then the third acknowledgement you would get is 377CA, which is called your a claim level information, or a CEM it's called. I think CEM stands for, I'm not given the full form here. Okay. So I'll find out what is this module. It's called editing module, common edit module basically. So there's another report that you would get back is a claims adjudicator information. Okay. So just remember these four types of reports. Three types of reports: TA1, 999, and 277CA. So these are very important interview questions for you. Any questions on these two exhibits that I'm walking you through? Any EDI transaction will undergo this process, whether it's an 837, 835, or any EDI. It's a basic, consistently, every organization will follow this. Okay, so let's talk a little bit detail on this functional acknowledgement. Remember when a compliance guide is violated, so this 997 is generated. Okay. So it allows for multiple ATM transactions, basically in each and every functional group. GS is your header and GE is your trailer. All transactions in a single group must be a single type, So that means what you're saying is, if you're generating a file, for example, one text file, it should either contain only professional claims, or it should contain only institution claims, or it should contain only dental claims. That's what it means. In case you mix up, then it will generate an error report called 997. In older version it's called 997, in the newer version it's called 999. So please don't get any confused here. All right, then 997 functional acknowledgements were generated for each functional group in an interchange. Okay, the functional acknowledgements include data segments, AK3. AK3 is just the name of the segment that you get back an acknowledgement. And the data element AK4 information when appropriate for the rejection. Okay, so there's an acceptance and a rejection. Okay, this is just an example, how the transaction looks like. If you see your header information, GS information, and this is your AK, which is tells that A stands for accepted and R stands for rejected. So it's that easy to identify. So in case you get a 997 or a 999 report, look for this AK5 segment, and if it is an A, it's accepted, and if it is an R, it's rejected. So that's what it means. And this is just an example just to show you, how a rejection transaction looks like. Look here, in the previous slide we saw A, right, and which is accepted, where R means rejected. So we can always go back and see, where this error is. So I've given some explanation here. So it will tell you this AK3, for example, is a service line where the error is. Okay. This is another example of how to look into an error in case you want to see, what these errors are. So always look for AK5. If it has an error R, then look for AK3s and AK4 where the error is. So it's not fully due to print constraint as given only the sample lines that are highlighted in red here. That's where potentially an error could be appearing. So that means the error is right here. Purposely we made 1 and number and in words ON1. That's where the error is. I think that's all I have here about the acknowledgements. Any questions so far on what you have seen?
This is Suresh here.
Yeah.
This code, Unicode, what you are showing, that is this structure with the various levels of processes going on. From a BS perspective, at what stage do we get chance to see this in EDI transaction, entire process?
What is, in terms of BA role, is that what you're asking?
Yes, in terms of BS role, at what stage do we get possible to see this coding structure? That is, you are showing that Unicode structure, right?
Correct. Yeah. See, when you go as a BA role, basically you'll be asked, see, you will be not generating this transaction, right? It's the EDI department will be generating the transaction. But in case part of an EDI department, first thing they will be asking you to look is to run some reports. There will be some system-generated reports to see if these files are generated. That's number one. And to verify if the control segments, there are some control segments and header groups like ISA and GS in the beginning, and also there are some trailers to see the receiver ID and the payer ID are in conformance with the CMS. That means each and every payer or organization which is generating these transactions will be given a unique identification if those information is correct or wrong. And then we'll be looking into the SP segment where it will have some control information like number of claims and the total dollar amount. So manually we need to check at random. So in order to check at random, we need to know what is an ISA segment, what is a GS segment, or what is a claim information. And we need to go to manually and see. Remember, there was a CLM segment and there was some dollar amount, right? So in that we have to manually check to see, pick a random claim and check it. That's the number one role of our BA. And second thing is, if there are some acknowledgement reports coming back, either from the provider or a clearing houses or from the CMS or from the state, then we need to debug and see what that error is, in which segment that error is, in which loop the error is. So all you need to do is pinpoint that error. In order to pinpoint, you don't have to really do a manual process. There are some compliance reports. I think in the last class I've shown you, for example, there's a clarity report that will pinpoint the error line and also tell you what level of the HIPAA level error it is. So you just identify as a business analyst, then you review that error with the subject matter expert from the claim side, because they are the one who is going to tell, yes, is this error kind of acceptable, or is this error that there's a workaround, and what needs to be done, or do we need to change the data and send it again. So as a business analyst, once the user group changes the data, you need to rerun the transaction to make sure the error is gone, right? So that's the role of a business analyst. And then there's another role that if you're implementing a conversion of 4010 to 5010, that for each and every mapping, which is the subject content for our next class, that he would be determining the gap analysis between the 4010 versus 5010, and then generating these files in a 5010 format in manual process, and then to streamline this 5010 process, then the EDI will be generating, and then we'll be reviewing and checking and testing each and every segment. We'll be testing it. So as a business role, business analyst role, and in that assignment, if you are in that assignment, I would suggest that you would run some queries against the database to make sure, like for example, run a small query to generate, to retrieve a payer name. Run a small query to submit a claim number and to get its total dollar amount. Run a query to submit as an input the claim number to generate all the 5 claim lines. So that's how you cross-check if the claim information is rightly represented in a transaction or not. Okay. So these are the different roles that you would be getting into, and the today's session would be really helpful to you in terms of knowing the EDA transactions, the structure, and how to interpret them using the PR3 documents or companion guide. And finally, there are some business rules. Every organization has a business rule. So we need to check if those business rules have been strictly followed. Okay. And for example, if it is not followed, then it will be errored out, right? So is the error coming out because of the business rule? So can we bypass the business rule? Number one. Number two, there are validations, and most of these insurance companies or providers, they call it as scrubs. Scrubs are nothing but it's just a violation piece of code or a rule. That means, for example, if there is no NPI in a claim, right? So we don't want to generate this claim and send to the CMS if there is no valid NPI. So we need to scrub that claim, meaning we have to stop that claim from sending to the CMS. But once we stop it, as a business analyst, we need to identify why it has been scrubbed. That means why it has been stopped from sending it, what is the error, and we need to fix it and then send it again. So there's a lot of reasons, opportunities for a business analyst to work on these EDA transactions.
Excellent.
Okay?
Thank you. Thank you.
I also have an additional information here, and I don't intend to go these information that I'm showing you right now, but it is just related to the acknowledgements that we discussed in the previous PowerPoint. So I will be adding that into our blog, so it will be helpful for you to get a better grasp of this. Some more examples, a little bit of a transaction and then an explanation for you. So, all right. Okay, so now I would, ask questions if you have missed anything. And I'm looking at the chat here. What is 20,000A, B, and 2300? So these are the loop numbers, like the 2000A is for your subscriber information, and then 2300 is for your claim information. So these loop information is in the TR3 document. For example, let me show you the TR3 document here. Okay, so here on the top here, do you all see this? So the loop number is right here, 2010BB. It is a loop number here. That means the loop contains the payer information. So they are NM1, which is a entity type here. C2 means it's a facility, right? Non-person means it's a facility. 1 means it's a person name. And then here is a payer name here, NM103. First name, middle name. Then, for example, if you scroll further down, so some fields are not used. So wherever it's not used, you will be having just asterisk, 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 etc. Then, so this is the same 2010BB, and then now it's the payer address. So it's just a loop number. And let me also show you the claim level information, 2300. I'm searching for claim level information. Okay, here. So the loop numbers are always on the top here. I don't know. Sometimes we overlook these numbers, but the document shows on the top here, 2300 claim level information. Okay, and I'm scrolling down here to give you more information. So here the CLM here, then 1234 is the patient account number, then followed by the dollar amount. So this is what we need to look into it and claim. Okay, so these are the different fields the claim level information has. The bold one or the required one. If you see the square border in bold, they are the required ones. So others are situational, and if it is striked out, means it's not yours. So that's how you need to interpret this document. And it's clearly here, like CLM1 means it's a claims identifier. Okay, and then CLM2 is a claim amount. Then similarly, there is a facility code. Okay, then there is a qualifier, the frequency code, etc. So all the information, it's like a Bible for you, it's like a roadmap. You will find all the information on it. So all you need to know is the loops, the segment, and the value here. Just search for anything that you need, and you will find it here. So start using it. And even if you try to do some web research on this implementation guide or a companion guide, there's a lot of documents. So I would suggest you to download at least one for professional, one for institutional, and one for dental, and start looking into it. Yeah. Any other questions that you would like? I've answered 2008 I think we talked about COBs. Okay. And service levels also we talked about. And if you have any other questions, yeah, please let me know. And this time I'll be posting some assignments. Basically, this is the document which I will be. This is the companion guide. They have given some business scenarios. Right, so in this table you are seeing some business scenario, right? So some elements are here and some values are here. So for this business scenario, how does the transaction look like? So the solution is also here. So try to read the business scenario and see how the information for the scenario is represented in a transaction. So it's good to understand. And there's another a scenario here. So what I would suggest you is to read this transaction, in this blue highlighted, like ISA segment to IEA. It's a very small transaction. Then each and every element here, for example, ISA is your 1, ISA 2 is 002, for example, and try to fill that information in this box here. Okay, and ISA is not given here, but at least from SP. See, for example, SP1, then SP2 is 837, SP3 is 007, okay, and fill that here, okay, so SP1, SP2, and SP3. SP1 is 837, and SP2 is 007. So in this way, you will get a good practice, how these interfaces are developed, how a mapping document is developed, and how a gap analysis is developed. So if you can do this small exercise, do as much as you can. I mean, if you do, fill this 2-page table, it's well and good. I have given you some examples also. I have prefaced so that, you know that you are in line with your thinking. And wherever there are blanks, try to fill it up. And only thing is this document is, I think it's a PDF document, it's an image. You won't be able to do it online. You need to print this document and then, manually write it. So this is just for your practice. Okay. I think that's a small exercise. So next class we will be talking about this ICD 9 versus ICD 10 and the mapping document too. So I will show you how a mapping document is prepared. It's an Excel document. It will give you the old 4010 and it will give you the new 5010, what each individual element comprises of. Then what is this DRGs, CPT and SIG codes, how they are represented. And we have talked today, we have also talked a little bit of the PR3 and companion guide. Okay. So the current project, if you happen to go to a 5010 conversion project, so this class would be important to you to understand the 5010 format. So fully we'll be talking about the 5010. That's our next session. And the final session would be on the facets, the data model, and the pricing methodology. Any other questions, comments, suggestions, observations? So I'm not hearing, that means you should be either okay or fully confused. Okay, so let's talk about when is our next class. As per our earlier, we thought that we would be having a class on 1st, which is coming Thursday. So you think you all are okay for having a class on 1st?
Yeah, I'm good.
Okay. All right, so we got a good response from Kanal. But Suresh?
Yeah, I'm okay.
All right. Yeah, that's good. So I'm hoping others also are okay with that. So we'll go as per the plan that session on Thursday, and then finally we will conclude on Saturday. Saturday we'll meet. Is it 3 p.m. in the?
Yeah, 3 to 5.
Raghu, like, can we skip the class from Saturday to Sunday? Because like on Saturday I'll be traveling, so I won't be able to attend the class on Saturday.
So instead of Saturday, we want on Sunday at the same time, like 3 p.m. Central?
Yeah, same time, like if it's not a problem with others, so we can do it at the same time on Sunday.
Anyone else has any objection to it? So we have not heard any objections, so let's make a decision to move our Saturday class to Sunday at 3 p.m. Central Time.
Okay.
All right, that sounds good. And yeah, let's call it a day. And please review this material. And I've been posting this information on our blog. So if you can, do this small exercise, that will give a good understanding and come back with questions so we can discuss as a group. All right?
Okay. Thank you, Raghu.
Thank you.